Bismillahirrahmanirrahim. My name is Dr. Faisal Shahzad, and today's presentation is about is basically for doctors and medical doctors, but a few questions might be of interest to authorities and ordinary people as well. Um, Basically, as I always do, I ask some questions and I'll let you do the thinking if you're interested. What was the name of the treatment given to Michael Jackson, and why was it was not repeated and why no one questioned? Um, One man changes his skin to from black to white, albino almost, um, and nobody questions that why this process has never been repeated on anyone, and why what is I'm a doctor, I don't know what's the name of the surgery. It's not given in any textbooks after more than two, almost 1.5 decades. What was the name of the device which what is the name of the device which reads ECG in automatic emergency defibrillator, and if there is such device, why is it not used in hospital settings? The answer is very complicated. There's a device in malls and places, and if somebody goes into shock due to any reason, it is attached to it and it gives it a shock. And you should know that the defibrillator is only used when there is ventricular fibrillation, and it's called defibrillator. In Suppose somebody goes in shock because of hypoglycemia, and his heart is faint due to um, um, changes in metabolic changes and due to changes in the electrolytes, and you give him a shock and he will die. So the question, while I'm not giving the answers here, what is the name of the device which reads ECG in automatic emergency defibrillator, and if there is such a device, why is it not used in hospital settings? And now this is a very sad aspect. Do you know, in Pakistan, everyone who becomes a consultant, I was forced to do uh, a fake research, but never had a heart to submit it. Um, but it's being done all over Pakistan and all over the world, and there is no one questioning it. And do I even need to mention what kind of problems it can lead to? And when it gets into a medical textbook, what can it do? And then the question is, uh, why is medical science when medical science is seriously lagging in finding new therapeutical products? Why is it not doing research in the products that are traditionally used, like Chinese herbal medicine, like the Tibbe Unani, like Ayurveda, like there are many other things? Why is the products used, why is no research is done on them? I'll be honest, doctors are being stubborn, and they don't consider anyone else anything. We have surgery, so that gives us the edge. But all these products which have been used for ages and centuries and millennia should be researched upon. And why no research on them? We have recently included ivy leaf extract, but and there are many other products which are, and almost all medicine comes from plants, but still it is not getting the attention, and not the major pharmaceutical industries are not giving any attention to this. Okay, the question number 4. While working with because in fact this will be question number 5, but okay. While working with neurosurgeons, we I know that whenever we receive a patient of stroke or patient who has decreased consciousness, we never give Disprin or clopidogrel or any blood thinner before CT scan, or before we have established that it is a stroke or an infarct. But while working in cardiology, I found we give every patient the blood thinners before. I agree. We give every patient blood thinner. Let me explain. We give every patient blood thinner for ST segment elevation or depression, without establishing that it is stroke or infarct. It is without establishing it is a hemorrhage or an infarct. Um it is agreed that hemorrhage is very less, but we have to see if it is an hemorrhage, it will get worse, and we have to go for angiography, and but it is included in all ACS protocols and all protocols treatments given. So my question is why, uh, when a serious number of a serious percentage of you, it's very less, but even if it is 1% or less, still they can get serious because of that, and we should give uh, we should give that in the protocols, its treatment protocols. That's my question. Okay, now because basically I am from ENT, so I have a few ENT questions. Um Laryngoplasty eardrum implant, which gives potentially benefit of about 15 to 20 decibels, which is negligible, and it might give you treatment for benefit of some ear irritation, minor uh, tinnitus you have. But if these usually it's done, um, and there are usually it's done for patients. Patients is asking for it, so usually I would say that our doctors do it before patient is asking for it, because if you see there is a establishment treatment that the big graft is that you give a cartilage graft and if you give a cartilage graft, it will give a barrier, and if you give any other graft, if you give any other graft which is solid, it will give a barrier, and it will be a hindrance rather than helping the sound system. And if you give a facial graft, or what is the benefit of giving patient anesthesia and all those drugs and all this just to give him a mental satisfaction? Because mostly the tinnitus and the irritation the patient has due to a small hole is um, negligible anyways, and the way it attaches to the annulus tympanicus is also questionable. No treatment given, no method given in any books how it attaches itself to the graft to the, and it's said that it allows to grow. So it grows into normal in 40% of the cases or so. So what's the use? Okay, the FES endoscope has limited ability to clear lateral parts of the maxillary sinus and frontal sinus, and yet it is increasingly advocated in for sinus surgery. My debate might cause problems, so I'll want you to concentrate on the words I have written and answer that questions, because FES is increasingly used for removal of tumors. Even this, our worthy professor of services, one worthy professor of services, even said that I am using it for removing huge angiofibromas, and which makes me question when it has little limited ability to clear lateral part of lateral part of uh, maxillary sinus and frontal sinus. So how can you do it? But still, they are professors; they can do whatever they want. Okay, this is another important question. This is I am putting into question the third most commonly done uh, uh, operation of ENT is tracheostomy on ICU patients, and I am saying that if we do endotracheal tube deflation, balloon deflation, and it will the factors are technically the same, so the results will be the same. So we shouldn't do it. This is what I'm implementing in this. You can read it, because uh, when you put the tube in, it's ICU patient has to go through a lot of trauma, and if you just deflate and deflate the balloon like we deflate the balloon of tracheostomy, it can cause a lot. It can cause a lot of, so you save a lot of problem for the patient going into the surgery process and all, and it can cause rapid decretion in the, yeah, I should do research on that and all that, but I have told you how research is done these days, and I would need funds, so why don't you give me funds if you are willing? The answer, okay, this might not have too much clinical implications, but still, I have while working in an ENT practice, and I have been given, although I couldn't get my ENT specialization degree because of that fake research I had, I couldn't submit. But still, I have been given an equivalent to consultant certificates by the senior most worthy professors of our Pakistan. Anyways, the answer usually given to lateralization of Weber to the affected ear in conductive deafness is that it is due to silence in affected ear. But due to conductive loss, the at rest cochlea responds better to bone stimulus as other cochlea is hearing the sounds in the room. But then question arises: shouldn't all hearing tests be done in a soundproof room? And why no one has noticed and or done these tests or give us accurate reason for lateralization of Weber to affected ear in conductive deafness? Thank you so much.